Hi, good evening. My name is Praveen Chatani. I'm a first year fellow at Fox Chase Cancer Center. And thank you so much for joining us tonight for the SSAT Resident and Fellows Education Committee's annual webinar on preparing for the general surgery boards. We have five incredible speakers for you tonight, each who is an expert on the subject that they're addressing, and they have prepared wonderful topics for you. I won't take too much time. I want to launch right in. Today we have Dr. Mary Hahn, Dr. Adriana Gamboa, Dr. Anthony Villano, Dr. Jessica Zaman, and Dr. Meredith Barrett. And I'll introduce each of them as we go. Start with Dr. Mary Hahn. Dr. Hahn is the current president-elect of the SSAT, as well as the chair of surgery and the Emil Holman Professor of Surgery at Stanford University. She's actively involved in surgical education, both at Stanford and within residency programs nationally, serving as the editor-in-chief of the Operative Techniques in Surgery textbook, and she holds various leadership roles for the American Board of Surgery. Dr. Hahn is first going to talk to us about, she's going to give us a general orientation to the components and requirements for ABS certification. Thank you, Dr. Hahn.
Great, Prav. Thank you so much. I get the slightly boring talk to give you, but talking really about what it is, the board certification, and just some tips and requirements for it, and kind of break it down. So this is the General Surgery Board. That's what you're here to hear about. And basically, you're all in, I would assume most people who are attending here are somewhere in their training, haven't taken the board yet. So the curriculum requirements are really set forth by ACGME in collaboration with the board. And so in addition to your essentials in general surgery, ACLS, ATLS, FLS training, as well as flexible endoscopic curriculum, and then the 6 operative and 6 clinical performance assessments need to be completed prior to being able to take your qualifying exam, with one little caveat there. You all know about the required weeks, but the board has really made some policy changes in the last several years to accommodate leaves that are sometimes anticipated or unanticipated, either from families, childbirth, or illnesses or family events that come up. So you can take up to 1 4-week leave, approved leave during the first 3 years of your training, and an additional up to another 4-week leave in the last 2 years of your training for a new childbirth or adoption, a seriously ill family member, your own personal illness, or bereavement. So added some flexibility into that training. So the first big exam will feel quite familiar to you, the qualifying exam. It's similar to the ABSITE in terms of the format of the exam, of a multiple choice question exam. It's offered annually, and it's done in a secure location where you usually have to go to a Pearson testing center. It's an all-day exam, 300 multiple choice questions, 8-hour exam, with some breaks in the middle of it, to just allow you to get through the entire exam. And with the qualifying exam, you have up to 4 opportunities within 4 years to pass it. So pass rates are pretty high. I should have actually gotten those statistics, but I think the pass rate for the qualifying exam is 90% or higher. A great thing that I think not everybody knows about, but I think this is a great improvement, is that you can now take your qualifying exam after your PGY 4 year, or kind of at the end of your PGY 4 year, instead of waiting until after your PGY 5 year, which is usually that crazy time between finishing your residency and starting your fellowship. Many people are moving and then studying and taking this exam. And I think this has been a great improvement to that. In order to take your qualifying exam after your PGY 4 year, you have to have kind of your program director recommend that you apply and that you meet all the requirements for sitting for the boards, with the exception of the case numbers. And then those have to be turned in your chief year before you can sit for the certifying exam. And if you were to not pass it at your PGY 4 year, if you were to take it then, it does count as one of your 4 attempts to pass a qualifying exam. The content of the qualifying exam should be very familiar to you. It's based on score, which I know most residency programs take advantage of. And so the score, it's basically mapped to the score curriculum to cover the breadth and depth of surgery. So once you pass your qualifying exam, yay, you get to sit for your certifying exam. And the certifying exam, I think, is the one that we all hear the legendary stories about of how stressful this oral examination can be. So it is the final test to getting your board certification following the completion of your residency program. It's offered twice a year, so once in the fall, once in the spring. And it is now since the pandemic, it is a virtual format. It used to be in person with 2 examiners, 1 examinee, and you have 3 30-minute sessions where 4 cases will be discussed during that session. And at the end of each session, then you'll kind of leave that exam room and put yourself into another exam room with 2 new examiners and a new set of 4 questions. And that happens a total of 3 times during the certifying exam. You have up to 3 years or 3 opportunities within 3 years to pass the certifying exam. And the overall first time pass rate in the certifying exam, I think, is 92%. The requirements for the completion of the certifying you have to pass the qualifying exam before you can take the certifying exam. You can only take it once a year. So if you were to take it in the fall and fail it, you can't take it in the spring. You would have to wait at least 1 year to retake the exam. And I also, if you don't select a date for your certifying exam, that's also lost opportunity. So when you make sure you have your proper contact information in with the American Board of Surgery when you finish your residency training. You have to have a full unrestricted license to practice in the US or Canada in order to register. And then because of the technology, you just have to go through a tech interview session just so we make sure that video, audio, the broadband, Wi-Fi, everything works to be able to conduct the exam. And then I know others are going to go through the tips of the certifying exam. But I thought I'd just talk about what are the examiners, because I'm still an examiner for the American Board of Surgery. So what are we looking for? And I'm going to go down to the second or third bullet point here. Really what we're looking for is candidates who have an organized approach, solid rationale for how they're going to evaluate and manage the scenario. Can rapidly determine and interpret key findings. Every once in a while, there's stallers who keep asking questions, repeating things, and then it makes it hard for us to get through the content that we're trying to assess in that scenario. So effectively and efficiently use your clinical knowledge to solve problems and address the key management points. So it's kind of like you're talking with a colleague. We want to kind of know what you're thinking, how you're thinking. Avoid errors and critical fails. I often tell my trainees, like, this is not the time to make up an operation as a unique way to solve a problem. These should be very straightforward questions and things that you should have seen at some point during your training. You can recognize your personal limitations. You could say, like, there may be a vascular question and maybe you don't feel comfortable managing it. You can say, well, I would ask for a consultant, a vascular consultant. They may or may not be available to you. Oftentimes they say, well, they're not available, but what do you think they would do? So at least you kind of have an idea of how they would manage it. Don't ask for a consultant on everything, but we know there are areas where can be super so specialized that you might not feel comfortable totally taking care of something yourself. And that if a lot of times we'll pivot a question and because we're kind of going down, we're like, okay, they know this. Let's kind of throw a twist in here, a complication, a different presentation. And so being able to react to that. Most examiners will try and put you at ease and say, if we do this, it's not that you're doing something wrong. We're just really trying to assess your knowledge and your management. And then most importantly, we really just want to know that you are a safe surgeon with good, sound judgment, professional, and a solid rationale for how you're going to manage a scenario. A little more, there is online in the American Board of Surgery, they have little mock-ups of exams, so you can watch a video of kind of what the scenario would look like. I know many of you probably participate in mock orals in your training programs, and those are good things to do. I know many of our fellows in our program, they kind of get together and give each other mock orals. So I think the practice is really important. Kind of makes the circumstance, which is very artificial, feel at least a little more familiar. So that's my brief overview of kind of the nuts and bolts of the qualifying exam, the certifying exam for the American Board of Surgery. Thank you.
Thank you so much, Dr. Hahn. We're going to move on. We do encourage you to put your questions into the Q&A section. Anything that is mentioned as a part of the talks, I can repeat and answer, but if there's anything that we want to throw out to our uh, discussants, we'll wait till the end of the Q&A. Next up, Dr. Adriana Gamboa. Dr. Gamboa is a member of our SSAT Resident and Fellow Education Committee, which we encourage everyone to reach out and join. She's soon to be graduating from Surgical Oncology Fellowship at the University of Texas MD Anderson Cancer Center. She's a prolific researcher. Her academic research interests and focus has been in complex GI malignancies. And whilst at MD Anderson, she's been a clinical informatics fellow using synthetic data generation for pancreatic cancer research. She will be staying on faculty at MD Anderson. Congratulations, Dr. Gamboa. We look forward to your talk. Thank you for joining us.
Thanks so much for having me. So I will be going a little bit more in depth into the qualifying exam, which I know Dr. Hahn touched on, but we'll just go through logistics and some study tips. So just going over general logistics, as Dr. Hahn mentioned, you have 7 years from completing residency to achieve overall certification. And you have 4 chances for the qualifying exam, which you can only take once a year. And again, 3 chances for the certifying exam, which you can also only take once a year. The exam is offered yearly, and you should apply after completion of residency to ensure maximum opportunity to take the exam. Though I will also point out that the most recent perk of being able to take it after your PGY 4 year is huge, and I wish I had done that myself. It gives you a little bit more time after completion of residency to move and start fellowship, particularly if you have a July 1st fellowship start. The test is held typically in July prior to fellowship starting on August 1st. Oops, sorry about that. So just to highlight the 2025 schedule, this year's QE examination is on July 27th, so just in a couple days. The application deadline is typically in April, and the late application deadline is about a month later. And you can see there the sort of cost for each of these applications. For the application itself, there is a form, and then you do have to submit your operative experience report as well as documentation of ACLS, ATLS, FLS, and FES. So where most people get sort of hung up in taking the exam as a PGY4 is your FES certification. So make sure you get that done if you have the opportunity to do it early, if you're interested in taking the exam early. As far as the actual exam day, the exam is taken at authorized testing centers only, so make sure you sign up early and you kind of select your preferred testing center so that it doesn't run out of space. It's an 8-hour limited computerized multiple choice exam with 300 total questions divided in 4 sections, so 75 questions per section. And there's a 70-minute break bank that you can sort of break up as you wish. Most people sort of break it up into 10 minutes and then a longer 40-minute break time for lunch. But I will say that you can accrue additional time if you finish a section early. It does go into your break. And then once you finish each section, you cannot go back to your previous section. A passing score is greater than 400, and the score ranges from 1 to 900. And results are typically posted about 4 weeks from the exam date. In terms of content, 80% of it is patient care with the breakdown that you see here. So this mirrors pretty much exactly what the app site content is as far as patient care. And then 20% of it is medical knowledge, with 13% of it being applied science, with all those small topics that you see there that you typically sort of review in the weeks leading up to the exam, as well as preoperative evaluation and then some other miscellaneous topics. And this again mirrors the app site content. So if you've been studying for the app site, you'll sort of know what the breakdown will be for the QE. In terms of study strategies, I highlight this particular study using the American Board of Surgery in training exam. And what was shown in the study is that the app site is more predictive of passing the QE, not necessarily the CE. So the better sort of your PGY-5 app site score, as seen on the figure on the right, the more likely that you are to pass the exam. And again, fairly predictive of QE, not so much the certifying exam. In terms of study strategies that have been highlighted to be high yield, this particular study highlights the fact that spacing and frequent testing are both pretty high yield strategies that have proven over time to sort of be the most helpful. So implementing a schedule of practice that spreads study activities over time, as well as self-testing or taking practice tests. And so this just highlights the importance of starting early so you can actually develop a good timeline. As far as study resources, I think most of us, by the time we get to the QE, are fairly well versed in what's out there. And if you've been studying throughout residency and studying for the app site, this is sort of common knowledge. But there are the core textbooks out there, such as Sabiston's, Schwartz, Pfizer's app site review, and then Virgilio's case-based clinical review, which are really helpful. This is where most people really, what most people really rely on, and it's question banks, with TrueLearn being incredibly popular. And it offers what I think is probably the best simulation of actual exam day questions, style, and content. And this is an excellent resource for just, spaced repetition, creating a schedule for yourself, and potentially doing this question bank a few times prior to the exam. And then there's also Score, where you can create your own study schedule and set your own timeline on Score, as well as CSAP, which is another fairly well-known question bank. Lastly, there are some systems like the Pass Machine that offer lectures as well as question banks, as well as the ACS Comprehensive General Surgery Online Review course. And then the last thing I'll touch on is sort of some study plans and tips, but make sure you start early, about 6 months out. Start rereading whatever your preferred major textbook is, or using Score and doing questions through Score. And then about 3 months out, start a question bank like TrueLearn, and this should really give you a fair amount of time to at least go through this question bank twice. And then the last final phase in the 1 to 2 months leading to the exam is just focusing on high yield reviews with Pfizer, CSAP, and potentially taking full length practice exams if that's helpful for you. That's really all I have. Feel free to reach out if anyone has any questions.
Thank you, Dr. Gamboa. Moving on, we'll be joined by Dr. Anthony Villano. Dr. Villano is an assistant professor of surgery here at Fox Chase Cancer Center, where I'm very lucky to work with him, and he's a member of the SSAT's research committee. Dr. Villano also serves in numerous leadership roles throughout academic societies, including the SSO, the AAS, the RAS, ACS. He's also the co-editor of the brand new Surgical Oncology Clerkship book, a guide for senior medical students. And as I recently just found out, Dr. Villano is the quiet author of a 100-page resource on the ABS CE. So he's going to talk to us today about preparing for the certified exam, also known as our oral boards. Thanks for joining us, Dr. Villano.
Well, thanks for that very kind introduction, Dr. Chaitani, and honored to be a part of this webinar. I'm just going to share my screen for you all. All right, so I have the pleasure of talking about the certifying examination. As Dr. Hahn alluded to, this is likely the one that causes the most stress for trainees. I certainly was in the same boat as you all not too long ago, thinking about this. And so I love that the SSAT puts together this resource for trainees to get more educated prior to the exam and maybe alleviate some of that stress. So one thing about the CE test that I really like that Dr. Gamboa presented some data around pass rates and the ABSITE and the QE and the CE. The CE is a different type of test. It's really a test of critical reasoning. And so knowledge of key general surgery topics and principles, although of course you need that to be successful on the exam, it's really sort of the baseline low bar. Like you need to be very familiar with that. And then where people get tripped up is largely the skill set one needs to sort of communicate themselves effectively. And we're going to get into a little bit about strategies for that. But this is really a test of not just what you know, but why you're doing things and how do you communicate that to your peers. And really, the examiners are not there to stump you. They're interested in having a discussion, like Dr. Hahn mentioned, and understanding how you think about problems and how flexible you are if things don't go exactly how you would have planned them to, which is all part of the exam. So a little bit about the format and grading. It is a virtual examination. Certainly, as you're preparing for the space you're going to be using for the exam, plan to be in a quiet area where you know you won't be interrupted. You know you don't want your pet kind of flying across the screen as you are taking the exam. You want a Wi-Fi connection that is very stable. And although you can be taking notes, you shouldn't have other things in the background like books or paper. You kind of want a very neat, organized looking space. As Dr. Hahn mentioned, you will have 3 rooms and there are 4 scenarios per room, so they go very quickly. That kind of gives you about 7 to 8 minutes per scenario, although I will say that not every scenario is built to be 7 to 8 minutes. Some may be shorter, some may be longer, and I would never read into finishing a scenario quicker than you thought. It may mean that you just hit every grading checkbox that examiner wished to gather from that scenario, and then you just move on. So don't read into scenarios going shorter or longer than that. It's just that you want to give yourself about that much time as you're practicing so you understand the cadence of each of how to do these scenarios properly. There will be 2 examiners per room, although on occasion there will be a third individual who is really there. It's an internal quality check, or they may be training to become an examiner, and so they're shadowing to some degree. The majority of the exam is based on core material and score, and then the remainder is either complications or what they label as advanced material. But I would say, from experience, the vast majority of the exam is core material from score. As far as the knowledge base goes, I think this arises fairly naturally through residency, through your years of training, your preparation annually for the ABSITEs. Certainly, I think the resources Dr. Gamboa highlighted for the QE apply. I would make it a goal to be finishing 1 to 2 comprehensive surgical texts cover to cover, whether that be Sabiston or whatever your choice is. Working your way through the SCORE curriculum, you'll have institutional didactics, and then there are some books that are better than others for oral boards prep. I really liked the clinical scenarios and surgery book, and so I highlight that one here. Really nice framework for thinking about the oral boards. The way the cases are organized are sort of in a manner that feels like as you're reading each chapter, it's like it's guiding you through a scenario. And then the earlier you can read this one, I think the better. In hindsight, I read this as a chief resident, but is a really useful resource as say like a PGY 2 or 3 going into your years will be doing consults. And so it was one of my favorites for sure. Now, as far as preparing to go through scenarios, I highlighted, this is somewhat of a skill that needs to be cultivated. And so, waiting a month or 2 beforehand and then starting to do mock scenarios is really not the way. I think the programs that do have structure built around doing mock scenarios with their residents are at an advantage because it really is, again, a skill that you cultivate over time. It's a little bit about understanding the cadence of how to get through a scenario. So how quickly to speak, how quickly one moves through the workup and gets into diagnostics, and then, what they're going to talk about for their recommendations. Speaking clearly and succinctly is very important. Staying organized in your approach is important. Again, the examiners want to see that you're not jumbled or disorganized, that you have a mental model through which you approach basic general surgery problems. And really the best way to cultivate that is practice. And again, we talked about mock oral boards. Some of you may be in regions where the ACS has local chapters that may be doing mock oral boards, which is fantastic. I would say, irrespective of those resources, doing mock orals with your trusted attendings is one of the best ways. And so don't feel shy about approaching your mentors at your institutions to work on them. Another resource that maybe is not talked about as much is your co-residents. And so this was in kind of a fantastic bonding experience for me and my co-chiefs. We spent a few months together meeting virtually on Zoom and spending about 1 to 2 hours a week with one another, sometimes more frequent than that, kind of quizzing each other on exam topics. And, believe it or not, you're all graduating chiefs at this point for the most part that are gearing up to take this exam, or your first year fellows. You are very knowledgeable in the fields that you are planning to go into for your specialty. And so you quizzing your co-residents usually is pretty much at the level that the general surgery boards would expect you to understand things, if not even a little bit more advanced. I would say that through practice, I felt like the actual day of the exam was a little bit more structured and easier to navigate than even the mock oral boards that I had experienced prior. And so in some ways, if you're practicing at a higher level, you will find that the exam day is easier for you. There are courses available. Osler is a very popular one. I never experienced that during when I took my exam. It was during the COVID era, so there were virtual resources that they allowed us to sign up for. But I've heard that that's a really useful resource. Behind the Knife also has oral prep course material, and so those ones I think are highly valued. A little bit about examination tips. Again, the organization and being methodical about cases is very, very important. You want to move scenarios along. So if you feel like you're getting stuck, you don't want to spend 5 minutes going through the H&P for your first scenario in a room, right? That would be problematic. You want to be able to get through all 4 scenarios. So you keep your answers succinct. One skill that I felt like was helpful is if you do feel like you're stuck, spending just 1 or 2 sentences rehashing the clinical scenario, so it buys you a little bit of time, kind of refocuses you, and then thinking about your next question and moving along. You don't want to spend too much time on the H&P. I will say that very often the examiners are going to give you the entire H&P. And so you may ask 1 or 2 clarifying questions that are pertinent to that particular patient. But if they fed you the entire H&P, it means that they really want you to start digging into the workup and the treatment of that patient. And another one is, sort of moving on from difficult scenarios. You will 100% encounter a room or a scenario where you felt like right afterward you didn't do so hot. That is okay. Everyone feels that way taking this examination. You're never going to ace every scenario. But the key is to not let that bother you. Don't get too emotionally distraught about it. Move on to the next and just keep rolling with it. The test goes by very quickly, and so you almost don't even have enough time to process the ones that are that you felt were extremely challenging. But take sort of some confidence knowing that even if you didn't pass a singular scenario, you can still pass the test. So I would just keep moving on when you have those experiences. Some pitfalls to avoid, kind of getting back to some of the things I talked about on the last slide, but being too verbose. You don't want to ask 1,000 clarification questions. You want to describe operative procedures succinctly. So, I would not start, for instance, you're asked to describe a right colectomy. You're not going to start describing what kind of skin incision you would make, that you would dissect through the subcutaneous tissues to the fascia. The examiners want to know that, the key critical steps to safely navigate an operation, that you're looking for key pitfalls of complications. For instance, if you're doing a right colectomy, you identify and protect the ureter. That sort of thing is what they're waiting to hear, not exactly how you would dissect through fat to get to the fascia. Describing things that you're not familiar with incorrectly is a big one. So if you encounter something on the exam where you are just plainly not familiar with it, or it sounds like it's something that a specialist would normally do, is it okay to say that? Is it okay to say that, I'm unfamiliar with that procedure. However, to my knowledge, I would do X, Y, and Z, or, in my usual practice, I would consult a hepatobiliary surgeon. However, based on my knowledge, I would perform this procedure as follows. That is a great way to sort of illustrate to the examiner that yes, this is outside your usual comfort zone, but you recognize that you're in a test and you're going to explain it to them. And to some degree, it's better to do that than to make up an operation or start describing something completely incorrectly. And I think that is about the end of my time. I, again, am very thankful for this opportunity. Great resource for the residents, and we'll stick around for any questions.
Thank you so much, Dr. Villano. That was excellent. Again, a reminder to put questions in the Q&A, and we'll address them at the end as part of our Q&A session. Before we move on, just two plugs. TrueLearn does offer full-length mock tests for the QE, and that's packaged in as a part of their question bank at a small added cost. As a writer for TrueLearn, I can tell you that we do save some of our best questions and highest rated questions for those, so it is a valuable resource. Also, Surge Boards is a newer resource for the CE that is gaining popularity. I myself used it and found it very helpful, so something to look into. Next up is going to be Dr. Jessica Zaman. Dr. Zaman is going to talk to us about common pitfalls and what to do if you fail. She is a program director at the Albany Medical Center for the General Surgery Program, the residency program. She's a longtime member of our Resident and Fellows Education Committee at the SSAT. She's also the chief of bariatric surgery at Albany Medical Center. Thank you, Dr. Zaman, for joining us today.
Thank you for having me. So, when I originally volunteered, I didn't think that I would actually be the one giving this talk. But I do think that this is important to walk through. So I will talk to you today about what to do if you fail the ABS certification examination. So, unfortunately, I have not failed the boards myself, but I have actually advised several people, several very smart people, who have unfortunately failed the boards not only once but twice. And I can tell you that taking the general surgery oral examination, even though on a day-to-day basis most of us may be in situations that the average person feels more stressed in, is an extremely stressful circumstance. So I think the biggest thing is to get out of your head. It's very important to make sure that you don't retreat inwards, that you actually go out and seek resources that several of the other speakers have been mentioned. So talk to your peers, talk to other faculty, and reach out, because this is very important to make sure that you're well supported, because half of the battle is dealing with yourself in this circumstance. And for most of you, hopefully this will be a preventative talk, but there are situations where people do fail the certifying examination. So I'll talk to you about implications of certification. We've discussed some of the examination policies, but there's a little bit of nuance when you're dealing with retesting. We'll talk a little bit about the statistics of who fails, and then what to do if you're in the situation where you've failed the boards, the oral examination. So, per the American Board of Surgery, certification demonstrates that a surgeon has met a rigorous set of standards and has the clinical judgment and skills. Sorry, I'm having issues with this. It has clinical judgment and skills for delivery of high quality care. There are implications for the surgeons, patients, as well as the healthcare delivery team. For the surgeons, it can affect your professional reputation. For patients, it's a essential assurance of certain quality, and this is the same for a healthcare system in assuring that that the hospital, who may not be a specialty in your field, can trust that you have passed the standards that are required. So this can impact you if you are not board certified. Some hospital credentialing committees require that you are board certified. In general, when you're first starting out in practice, there's a ramp up policy with many hospitals. It can impact your reimbursement. Several insurance payers actually will not reimburse to the same standards if you are not board certified. It can have potential implications for job opportunities, but specifically if you are in different surgical subspecialties such as surgical oncology, pediatric surgery, hand surgery, and it can impact your eligibility for research grants. So, what do you do if you need to retest? So, several others, Dr. Hahn, Dr. Gamboa have alluded to the 7-year policy. This is actually per the American Board of Medical Specialties, that they require that you complete certification within 7 years. And so the Board of Surgery has done it so that you have 4 years to pass the qualifying examination, 3 years to pass the certifying examination. So you have a maximum of 3 opportunities, and this is over a 3-year period. Now, it's important to remember that that time period is absolute. So if you decide not to take it within a certain year, you've essentially given that opportunity away. So it's really important to make sure that you sign up appropriately. And if, for example, that particular, you can only retest once per year, if there's a situation where you're trying to retest and that particular day is full, there is definitely policies in place. And so you can reach out to the appropriate entities that would be listed there. But that is definitely something that you should definitely not give up an opportunity. So let's just say that you're no longer eligible. Let's say you've passed the 7-year window or the 3 attempts. And so there are different pathways that you'd have to pursue. So there's actually 2 of them. One is the standard pathway and one is the alternative pathway. So in the standard pathway requires repeating some sort of training. So it would be chief resident level training, or for example, an ACGME accredited fellowship such as trauma critical care, or another ACGME approved pre-approved fellowship. And in this situation, you would have to have quarterly reports submitted by the program director at that institution. And then you would need to be assigned a faculty preceptor that would work with you on completing a couple of educational requirements. So you would need to complete CSAP, the most recent module, and then they recommend monthly mock oral examinations. So this is a standard pathway. And then there's an alternative pathway where you can pursue that education and re-education on your own, but at the end of it, you must pass 175 to 200 question written examination that's more designed for being in practice. And you have to sign up for this before February of each year, and it's offered between March and May annually at a secure examination facility. So once you pass that readmission examination, then you will be eligible for the certifying examination again with the 3 opportunities over 3 years. And during this time frame, if I know that many of you may not know this, but you're actually able to go to the American Board of Surgery website and look up who's certified. So at that point in time, if you are not certified, it'll list that your examination is in process during that time frame where you're working on taking that examination. So who fails? So these are some of the statistics that Dr. Hahn was alluding to. So the qualifying examination pass rate is about 90+%. In the time when I was taking examination, the pass rate for the certifying examination was actually 75%. But over time, that has actually increased to 83 to 89%. But that still means that there's about 10 to 15% of trainees who are not passing an examination on their first attempt. All right, so there is a lot of literature on who passes examination in the first time and what are the implications. So as Dr. Gamboa alluded to, the ABSITE scores do correlate with the qualifying examination performance, but it does not correlate with the certifying examination process. And things that do correlate are your performance at your local or institutional mock oral examinations. And believe it or not, your step 2 CK and step 3 USMLE scores also correlate to performance on the examination. Another important thing to remember is don't delay taking the examination. Now, I also don't suggest taking the examination when you are prepared, because that definitely is important. But as soon as you can, when you are able, it is very important to take the examination early because as you get more and more specialized, you take more and more time away from your experience and exposure to general surgery. So that is something that I saw several studies on. So what to do if you failed? So, as I mentioned, one of the biggest things is getting out of your head. So I looked up a couple of Reddit posts. There's actually a thread on Reddit about what to do if you failed the general surgery oral examination. And several of them really allude to that mental state of mind. But there's also some good resources that they've mentioned. And I think these are resources that have already been alluded to by several of the other speakers. I think one thing that's important to remember about the mock oral examination is that just reading a textbook isn't necessarily going to correlate with improved performance on the exam. You really have to practice, and that's kind of where it's important not to retreat. This is a little, I'm probably dating myself, but one of the exam resources that we used to use is How to Win, and on the author of that actually had failed the oral examination as first attempt and then prepared that resource as a resource for others. And it talks about that important need to practice and to kind of do some reflection and get beyond that mind game that I discussed earlier. There are some structured courses. American College of Surgeons actually offers that course, as several others have mentioned, and I think that this is I believe that it's a paid resource, but it's extremely valuable. The Osler Institute, I believe now that they're doing the courses in person again, but I'm not sure if that's appropriate because the actual examination is a mock oral examination now as well, or as a virtual examination as well. And there's other virtual mock oral courses through several societies, such as SAGES, and resources through other societies like the SSAT, such as this one. I think that it's very important to refer to surgical textbooks. I think the ones that are written in a more clinical manner, such as Cameron's and clinical scenarios, are excellent. Obviously, it'd be best if you started using these resources, in your later years of residency, mid to later years. But I think that they're very important in preparing for the examination. It's important also to make sure that you're preparing based on the score content. And lastly, some of the other resources that are more recent, the Behind the Knife oral board review, and then surge boards. I have several of my graduates that have told me about this resource. I believe that there's about 100 to 200 scenarios, and they're kind of active learning modules that you can use. And a lot of people really like this resource. And I think helpful hints is make sure you start early, be clear and concise, manage your time wisely, and maintain professionalism. All right. Thank you.
Thank you, Dr. Zaman. Last but not least, we'll move on to Dr. Meredith Barrett. Dr. Barrett is an assistant professor and transplant surgeon at the University of Michigan. She is passionate about surgical education and resident wellness. He founded the Women in Surgery program at the University of Michigan and has been one of the leading proponents of mental health awareness and work-life balance in national discussions. Dr. Barrett will be talking to us today about what to do if you fail and common pitfalls from the trainee perspective. Thank you for joining us, Dr. Barrett.
Thank you guys, and thank you for that. Thank you for the invitation, and thank you for that introduction. Yeah, I will be talking about common pitfalls and what you do if you fail. So, just to get going, common pitfalls of board exams. I think a lot of this has been highlighted already, but overconfidence. We want you to go into your board exams confident, but being overconfident can be a killer. So I think don't rely on your ABSITE scores or your mock orals to necessarily suggest that you're set and ready to go. I think underpreparedness is a common pitfall. So for the QE, study, 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 use the resources that have been listed already. For the CE, study, 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 and then practice, practice, practice. I think setting yourself up for success is really important. So ideally, you should try to give yourself a day or two off prior to the exam. I know that July, particularly after your chief year, can be busy if you're moving and trying to set up a new life somewhere. So I agree with the previous discussants that taking the exam after your fourth year, if that makes sense to you, is a good opportunity. And if you can't, I think really trying to set yourself up for success by not planning to, move your whole house a day before the exam or do something that's super taxing either before or immediately after that could add stress to an already stressful period. And then it's important to get good rest, food, and hydration prior to taking each test. I think can be stressful, but as best you can, try to sleep the night before. And if you're kind of studying with friends for any of these tests, I wouldn't recommend, having a last night study party of any sort. And then I think utilizing the breaks in any of these testings is really important. Particularly the QE is long and it can feel kind of, we're efficient humans. We like to get stuff done, but going at your pace and making sure you take the time to take a break and get out of the location where you're taking the test, take a drink, get some food, walk around for a little bit, I think helps kind of clear your mind and get you ready to do better. And this is the same for the breaks during the CE as well. I will say that when I did the CE on virtually, there was like a little moderator who was there in between my break sessions, and she was so kind and lovely and made me relax in between breaks, which was quite nice. So common pitfalls of the oral examinations in particular. So I think it's really important to put on your listening ears and listen intently. I know for one of my oral board questions, I misheard the age of a patient scenario, and that kind of threw me off entirely with regard to what I thought was going on, because I thought the patient was a 63-year-old patient with one issue when they were actually a 23-year-old patient, which kind of changes your differential diagnosis. So really try to make sure you're in a place where you can hear well and listen clearly. I think this has been stated before, but avoid rambling and use clear communication. There's a very limited time frame in which you get to speak. So practice, 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 and really try to be clear in your communication. I think leaving out key details, a lot of the things that when we're kind of talking about operations, you don't want to make an assumption that the examiner knows what you're talking about. So you don't want to go rambling into things and kind of being overly complex, but also make sure any key details you suggest so they know what you're thinking. And then you don't want to get into too much complex detail. I think getting into complex detail, particularly if you don't have the expertise in that area, can get you into a bad place. So answer the question, be a safe surgeon, give the detail that you would assume is required to answer the question correctly, but don't get yourself, off into the weeds with regard to how much complexity you're suggesting. And I think it's really important to practice like kind of moving on after a challenging case. This has been discussed before, but if you get in your head about one case and then suddenly you're in the next room or scenario and you are focusing on the last case and you lose sight of what is going on currently, you can then take one bad scenario, which will not cause you to fail, and then take it on to the next sessions and then can potentially, risk your chances of passing. And then for today's day and age in Zoom, it's really important that you pick a good location with good internet connection. I think everyone knows kind of where that is and where it's not. Everyone's been on a Zoom where they've had kind of rough internet, so just avoid those locations. And so what to do if you fail? As you might recognize, I'm a transplant surgeon, so I'm not necessarily in your field, but I was asked to give this talk because I failed. So this is my examination history. I failed the certifying exam in 2019. As you can see, I took it again in 2020 and thankfully passed. And don't worry, it's not like this is out there for everyone to be able to figure out who failed. So the reason why I was asked to give this talk is because I wrote about this. And so I was able to write about my experiences. And then, like I said, was able to pass the following year. So what to do if you fail? I think it's okay to be frustrated and sad and upset. I don't remember a ton about my exam, but I do explicitly remember when I got that test result. And so I think I remember being on rounds with my team and it being overwhelming. I thankfully had my team there to support me. I think, it can be overwhelming, but giving yourself time to process, talk to others. It's hard because if you've taken the same time of a lot of your classmates will be celebrating where you feel ashamed. These are all normal feelings. So give yourself time to process. I don't think that this is the time to like go try to create a study plan or study or reflect on what you did wrong. Um, I think it's also really important to try not to question your intelligence or your clinical ability, as Dr. Zaman suggested, or it was in one of the Reddit conversations. People know people who fail who are like incredibly smart, talented surgeons. So it's not necessarily a reflection of your clinical ability. Most of us, when we find out that you failed, you're in some type of clinical scenario. I was my first year of transplant fellowship. So it's important to continue to be confident in your abilities. And this one test is not reflective of the 5 to 7 years you've spent in training. I think trying to leave the test in the past is important. So perseverating on what scenario you did poorly on, and I put what you answered wrong in quotations because it's, a very complex and nuanced decision with regard to who fails. Not to focus on that too much because you're not going to have the same questions and that doesn't necessarily help you. So trying to move on without focusing on exactly what went wrong. And then don't call the ABS and tell them to change your score because they won't. So how to move on and pass it the next time, because this is also from personal experience. I think developing a study plan, you'll be a further year out from your general surgery training if you're in fellowship. So intentional studying is crucial. On the flip side, unlike, when you're taking the test, if you take it kind of early in your potentially your fellowship or your new faculty life where you're just really experiencing a lot of change. When I had took it again, I had a whole year to prepare and was kind of more stable in my fellowship. So though I would not recommend failing, I do think that there is some potential there to really kind of engage and study for a whole year. Practice, practice, practice has been suggested before, which might mean working with a class below you to study. And then I think considering a review course, the data is not supportive, but I think it can be helpful to really just force you into encourage or into dedicated time for studying. So if you pay for something, I think you're gonna be more likely to kind of really focus on that studying. And then I think it's really important to work with your fellowship or your partners who you're in practice with to get appropriate time off around the boards. I took like a week off to study, 2 weeks before the boards, and then I took the day off before and the day of the exam just to be able to relax. And so finally, hopefully this is not you. Hopefully my story is not yours. I think that when I failed, it felt very much like I was wearing this scarlet letter and that I was very ashamed and that I was like a problem for my general surgery class because I messed up their statistics. But in the end, failure does not define you. We all fail at certain things and it doesn't necessarily make you a horrible surgeon. I am now practicing in my dream job. I am the director of surgical pediatric kidney and liver transplantation at the University of Michigan Mott Children's Hospital. And I'm not saying this to brag, but I'm saying that that thing is not anything I think about on a daily basis. I really hadn't thought about it recently until I got an email asking me to participate. So if you are to fail, which I hope you don't do, there is light at the end of the seemingly very dark tunnel, and you can be a successful surgeon even if you have this experience. So you guys got this.
Thank you so much, Dr. Barrett. Just really appreciate you sharing and joining us today. Um, we don't have many questions in the Q&A. We have about 5 minutes left, so I'll start by throwing a few out to our discussants if you want to turn your video on. And in the meantime, if anyone has any questions, I would encourage you to put them in the Q&A box. We'll start by addressing the recent change in the last 5 years to virtual testing for the CE. And I'd love to know your take on how important it is for examinees to practice in the virtual setting, not just with mock orals, but also with their peers. If I'm studying with my co-fellow should we take that extra effort to, instead of sitting next to each other and practicing, put ourselves in separate rooms and do it on Zoom? How important is practicing in that technical element? Maybe we'll start with Dr. Villano.
Sounds good. Always put on the spot by Dr. Chitani, so nothing's unusual here. I guess I have an odd take on that because again, my exam occurred like in the COVID times, and so we were forced to sort of study virtually. But that being said, a lot of it, like we were chiefs, like we were graduating. You may actually end up studying because you're with your co-chiefs because they're in different geographic locations. I would do that. I think studying on the virtual, like studying over Zoom with one another, does a little bit of a better job of simulating what it might feel like just to sit in front of a computer screen, avoid like looking in 15 different directions as you're speaking. May give you sort of more of that, like, especially if you practice like in the same location, you may take the exam. So it's sort of that familiarity of just being in an environment where you become comfortable because like you've built confidence with your co-chiefs or whoever you're studying with over time may actually make you feel more at ease the day of the test. So I love that idea. I don't think it's incorrect to study in person, but I found it convenient, and I think it may actually foster some extra confidence. I don't know what anyone else thinks about that.
Yeah, it's a very good point. And Dr. Gamboa, perhaps?
Sure. Yeah, I totally agree that practice is probably the most important thing. So whatever setting you find yourself in to do it, just do it, right? If it's over the phone, some of my co-chiefs and I would just call each other on the drive home and like give each other scenarios. But I do think there's a nice aspect of practicing via Zoom so that you get used to where you look on the screen, what your demeanor will be, make sure you're set up, in with the background that you want. And there will be an IT check for the actual test day. But my take on it is that practice as much as possible, and if some of it will naturally happen over Zoom, I think.
Yeah, I would say that we've actually talked about like for our when we do our mock orals, like for our institution now, we do them virtually as well too. But when we practice, it's in person. But definitely you notice some individuals because human beings are I'm very into this because I have children who are, going through this and trying to protect them from, technology is like a very, big priority in my life right now. But people process things differently when you talk to somebody in person and the visual cues and things like that you have versus when like some people come across very differently in two dimensions. And so I've just noticed this experientially from like way we practice like during education time versus when we practice like via like the virtual platform, people come off a little bit differently. So the more you practice, when you're taking the board, you're going to be the most stressed that you've ever been in your life. So if you practice as much as you can, but bottom line is practice however you can. But if you do simulate the virtual and you actually pay attention to all the stuff like your body language, like distractions, things like that. That is, anecdotally, I feel that it's very helpful.
Yeah, I had the lucky experience of doing both. I did it in person and virtually. And I agree. I would say that I think the virtual experience is quite nice because, they only see this part of you. So if one of your ticks is like being jittery. No one knows that you're being jittery underneath the screen. But if one of your ticks is being jittery to the point where you're moving around like this, it's very distracting. So I think having the ability to have someone kind of watch you virtually and let you know if there's anything distracting in your activity or in the background around you, I think that can be helpful. And then also it helps to determine, I would do it where you're taking it, as Dr. Villano suggested, to ensure that you have good internet connectivity.
Yeah, that's a great point. I took the citywide mock orals in Philadelphia, and one thing that came out of that experience, and it was given virtually, was that I have a tendency to look up when I think sometimes. And in a normal setting in a hotel room, that may not come across as weird, but when you're looking at me on Zoom, if I'm looking up, it's a little bit of a red flag, especially to the moderator who's looking in, because I could be looking at, something behind my screen and it's distracting to the examiner. So personally, that's something that I had to work on, making eye contact to not distract my examiners. Um, we're right at the 1 hour mark, and so I want to thank you all for joining us, and thank you to our participants for tuning in, watching live. This will be available on the SSAT website in our webinar section, so you can come back, revisit the talks, revisit the slides. But again, thank you all, Dr. Barrett, Dr. Zaman, Dr. Villano, Dr. Gamboa, and Dr. Han, and Bev, of course, Bev Hendry has set this, as she does with all our webinars, set this webinar up perfectly. And thanks for joining us. Have a great night.
Thank you.